I am very pleased to introduce you all to Dr. Dennis Mihale of Upward Health, the Chief Medical Officer there. And we're really fortunate to have Dr. Mihale talk to us today because he is really a pioneer in telehealth. And as we've already talked a little bit about today, that's really been such an area of opportunity in the past year plus as a result of the pandemic and some of the adjustments that we've had to make in order to stay safe during this whole event. So Dr. Mihale will talk to us today about building and sustaining the success of telehealth, lessons from an early adopter in COVID-19. And I think we'll all hear a lot of interesting lessons learned from this presentation. So with that, I will stop my sharing so that Dr. Mihale can begin his.
Okay, it's small, but all we're doing right here is taking some lessons learned from people who are an early adopter. And to be truthful, we had been doing telehealth for 9 years. So for us, it was a little bit easier to switch over. One day we were doing telehealth and the next day we were doing telehealth and COVID. So I don't want to think that we're smart, we're faster than anybody, we're better. We had just been doing it for years when we started doing it for COVID. Next slide. So I don't think you need to know about me. Facilitated virtual care. This is what's different. If you are talking to people who are seniors, 38% don't have the technology and skill set to do telehealth, no matter what anybody tells you. But with a facilitator, they can. So it's bringing someone into the home to bring the technology to the individual and to facilitate the visit. Happens to also allow them to do vitals, check meds, look at the environment, review social determinants of health, do a whole bunch of other things that are important to the patient. But most importantly, they bring the technology in. So the only thing the patient has to be is a patient. The satisfaction, the ability to bring specialists, the ability to bring any clinical person into the home is phenomenal, and our patients love it. Surprisingly, our doctors love it. They're a little afraid the first visit, but they love it. Next slide. The next slide shows simple tools, and there's a lot more. If you're going to do it, I would suggest that you have at least the equipment for vital signs, which would make sense. Since diabetes is such a challenge for everybody, you'd want a glucometer, a spirometer makes sense. We have digital stethoscopes. You can add whatever you want. You might specialize it to your practice and to your patient needs. The idea is that in real time, the doctor is hearing, listening, seeing, and evaluating the patient in their home. And I want to make it clear, the patient doesn't like to wait in the office, and the patient probably feels more comfortable in their home. Next. So what are some of the benefits? Certainly hands-on care delivered by a multidisciplinary team. Remember, the facilitator is there. They might be an LPN, they might be an RN, they might be an RN with special skills, they might be a nurse practitioner. Every patient is partnered with a care specialist. I want to explain why that's important. We develop a relationship of safety and trust with that patient. It's the same thing that happens in a practice. They may have a nurse or somebody in the practice that they trust. That ability of safety and trust allows you to really carry out the treatment plan. So you can diagnose, you can prescribe, you can assess, you can do everything that's necessary for a complete and comprehensive visit. You can do social determinants of health, behavioral health, which personally I've been doing for 8 years using telehealth. We call it telepsych. It's nice to avoid ED visits that are unnecessary. It's phenomenal for transitions of care. Readmissions happen because the patient isn't seen within that 7-day period. Sometimes they can't get in, lots of other reasons. I had a patient who was in Canada while I was in Rhode Island, and I was able to do a follow-up visit. You can address and solve social determinants of health over the phone and over the video. You can do quarterly assessments, and you can even do visits with new providers. So think of the specialists who are seldom going to get out of the hospital: the neonatologist, the hospitalist, the orthopedic surgeon, the endocrinologist. You can bring the doctor to the patient. Next. If you look at this list of summary of services, there's nothing unique about this. What's really unique is that it's hard to find something missing. If you can do it in an office, you can do it remotely, you can do it with facilitated care. There are even people who have portable on-demand systems, so you can bring almost everything. You're not bringing a CT scan, but you might drive it to the outside and have to get them from the house to the sidewalk and into the van. I don't think we do that. I know we don't. I'm just teasing. But these are the things that you can do. And if you look at them, most of them are things that the patients want and you want. Let's take a look at the next slide. So again, facilitated virtual care is no different than telehealth that you do today that's interactive, audio, video, except somebody's in the home. They're making the technology transparent. Patient doesn't even have to worry, and they're able to do a lot of other things in the home. They look in the medicine cabinet. They show the pill bottles and the pills to the doc. They check the electric bills, the water. They check the refrigerator. They're checking the entire situation, the whole person. So you've got access, but let's be honest, telehealth solves the access of transportation. You solve social isolation, more so than just the telehealth, persons in the home. The need for a physical exam, for testing, for real-time assessments. I don't think telehealth allows you to draw blood or do testing. Again, you could order it. I'm trying to be honest and fair here. You can create and advocate a relationship of safety and trust. Probably more important than anything else you're going to hear today. We had a problem with people returning to the ED, with people returning to the hospital. When we started our transitions of care, we found that we were able to reduce future ED visits, future admissions, and readmissions. Very difficult sometimes to educate the family. We find that when a patient leaves the hospital, 2 days later, they don't remember everything they were told at discharge. The discharge orders, they've got new meds, they might be duplicate. Going into the home 4 or 5 days later, speaking to the patient, reminding them of why they got into the hospital, what was the problem, asking if they understand the treatment plan, do they have their meds, do they know what a red alert is, which is why to call the doc. All those things go such a long way to making that patient feel comfortable and recover. Next. So quality improvement. I've done a lot of quality improvement programs in my life, more maybe than I care to admit. You can check on the impact of quality in programs, not just subjectively, but objectively. You can go into the home, the facilitator can evaluate the environment, evaluate whether the patient is following the treatment plan, take vitals, make assessments, truly understand if the quality program is delivering improvement. They can respond to deficiencies. They can take advantage of opportunities. They can work on education and self-care. We heard about self-care in the previous presentation. They can improve engagement. If there's one thing we've learned is if you improve engagement, you improve the quality improvement program. Obviously, outcomes can be improved. I don't want to read all of these to you. Number one, patients may not call you when they don't understand something. But if they have a visit, they'll open up. You can address exacerbations. Most importantly, you can respond to same day, next day needs by the patient. If you don't have a policy of same day or next day visits in your office, you're going to have more ED visits and admissions than you deserve. Sometimes the patient can't get there the same day or the next day, so you have to go to them. And that's what this is all about. Next. I want to make sure I'm doing okay on time here. So you can deliver comprehensive care. We use an interdisciplinary team. So we've got PCPs, behavioral health specialists, psychiatrists, nurse practitioners, both behavioral health and regular, nurses, LPNs, nutritionists, social workers. It's an entire team. You're going to see about it. And we can meet at one time. Try doing that in a conference room when those people don't work in the hospital. Real easy to do it through telehealth. Again, that facilitator is going out remotely, not in person, but remotely, setting up this session with everybody. So they just click a button and they're in the meeting, and and the notes are being taken. The follow-up is there. Next. So let's take a look at the benefits. And I try not to be biased or egocentric. I try to look at it from the patient's point of view. What do they like about it? Well, they like the access to care. They like the fact that it's responsive and timely. Patients don't like being told, come in 2 weeks to a problem that they have. They like the lack of transportation. They like doing the visit in their home. It can reduce the total cost of care for the patient. They've got copays. They get expensive at the hospital. One of the things that we found that I didn't project, I didn't predict it, was reducing the health inequities. We thought it would improve the health of populations, but we didn't realize what an impact it would have on health inequities that we're seeing about and reading about today. And it does create a relationship of safety and trust. Next slide. This is the team, and on the Upward Health side, you can read these. What might surprise you is the use of paramedicine, community paramedicine. There are times when somebody has to go out in the field, stabilize and treat the patient. We want to try and keep them out of the hospital if they don't have to be there. Obviously, we're working with the providers and with the health plans. In many cases, we are a surrogate PCP when we're facilitating that visit. We're bringing our observations, all the information that we see in that visit, back to the PCP, who may not be us, maybe someone else. At the same time, when we go out, we're knowing the treatment plan and we're being an advocate for that PCP and his or her treatment plan. Next. This is kind of a summary slide. I think I've covered it. In the sake of time, I'm going to skip it, but certainly you can ask me questions on it. This is sort of how we leverage facilitated virtual care in our population, which, by the way, our population is the highest 5% of risk, need, utilization, and the lowest engagement. So we only take the top 5% of a population, the toughest to manage and treat. Next. So the one thing we learned when we were looking at improving the health of populations is that 5 to 10% of patients with chronic disease may not have seen their doctor in 12 to 18 months. I have a friend who runs a IPA, 66,000 members for patients for him. 3,000 never get in to the office. He can't treat them. By the way, he's not treating all 3,000. Yes, no. But he wants to use our service just to be able to get his doctor out into the home. These people lack the annual wellness visit, the preventive visits. The care coordination is very difficult. Social determinants of health are extreme challenges. You really have to get into the neighborhood and home to do that. Adherence to a plan is a guess. Really is tough. Quality metrics, we always get asked to help with HEDIS measurements, because most measurements or HEDIS scores that can be done in the office are done in the office. They're completed. We don't ignore them. It's the ones that happen outside the PCP's office that are so hard. And that's where facilitated virtual care can help. How do you measure an HB1AC without a visit? Yeah, and you can order someone to come into the home. A lot of people, especially seniors, don't like having a lot of people coming into their home. But if you can have a relationship of safety and trust with that nurse, then she or he can do the test, or they can bring in someone. Lastly, you can use RPM, remote patient monitoring, to measure hypertension, asthma, diabetes, so you know when to go into the home. Next one has to do with addressing health inequities. Most of them are results of social determinant of health. They reduce access, they interfere with care management, they just get in the way. And it's terrible, but as a white physician with a high income, my family enjoys very good health care. That's not true of the populations we treat. And we try to reduce and even eliminate those health inequities. If you've got someone who's worried about housing, food, a legal problem, transportation, keeping an appointment at a clinic is difficult and maybe number 10 on their list for today. I learned it the hard way, but somebody really kind reminded me that if you're a mom and you've got an appointment and the doctor's running late and your daughter's getting off a bus and walking through a neighborhood that many of us might not want to drive through, she's at the bus stop, and to heck with your appointment. Those are the people that we go out. We bring in a facilitator, we deliver that care, we bring the doctor in, and we accept the fact that her life is more difficult than ours, and keeping an appointment is not so simple. Next. Addressing social determinants of health. Obviously, I've talked about it: transportation, same-day clinical needs. Our facilitators will stand in line to help people with criminal, legal, housing, and food. And you might ask, why would you do that? Well, until you solve that problem, your patient can't think about self-care. and they're not going to join you on a journey toward better health. Behavioral health is just so simple. In fact, we are working with someone who believes that behavioral health in our version, facilitated virtual care or telehealth, is better than in the office. Safety and comfort of the home, no waiting in the office, no transportation. I'm not going to read it to you, but there's a very nice from the World Health Organization, as I remember it, on social determinants of health and why it is so impactful. The American Hospital Association says that 80% of all healthcare dollars are traceable to social determinants of health. Next. I think we're getting close. Obviously, this shouldn't surprise you, this slide, reducing the total cost of care. We are going to improve access and quality and reduce exacerbations. We're going to reduce avoidable emergency room visits and avoidable admissions. Let me, for honesty's sake, let you know I'm an ER doc. If a patient needs to be in the ER, I want them there now. But if they don't need to be there, I prefer they stay home and let us treat them in their home. We think it improves compliance, and we think it increases self-care. Some patients need to be shown things 5 or 10 times. Some of our doctors, and you might be looking at one, need to be shown technology and how to get the camera on 10 times. So let's not judge them. If we have to go out 10 times to get them to improve the quality of life and the quality of care, that's what we'll do. Next, this is one of our studies, so I don't want to say that it's universal. We reduced ED visits by 40%. Actually, it was a little more. Inpatient visits by 25%. We increased primary care visits in the last 90 days remarkably. I mean, it was just, you wouldn't believe the number. The patient using something similar to the CHAP score gave us a 9.8 rating. I always laugh when I read that because I can't get a 9.8 rating from my wife. I can get it from my grandkids. But other than my grandkids, nobody ranks me 9.8. So I feel pretty good about this. So the last slide is the summary. I'm not going to read it. I want to leave some time for questions and apologize for having so much difficulty getting started.